So as I've been welcoming everybody, thank you. Thank you. Thank you, Mr. Matsejo, for joining. And that now we have our case presenter with us. We are grateful for this moment that we're going to have. I've been reflecting on the years we've been running this program. Now it's the third year. We started on the second week of January 2022, and now we are in 2025, still unpacking palliative care. So it's been a long journey. Yeah, it's been some time sharing the best practices. For those who may not know, you can find all the videos, almost or 99.9% of the videos we have in this program in our YouTube channel. Termed Eco Eswatini Hospice at home. You will find all the videos in that channel in our YouTube. You can watch them in our last previous session that we had. But not to waste time, let me just say that we are looking around the end of life. So we are considering what best practices we can share together as far as end of life is concerned. So let me also announce that if you have been able to follow our IECO platform, you will notice that now in a year we are having 10 or 11 sessions. Actually, we are having 11 sessions per year. So we are going to hold our sessions annually, monthly, every first Wednesday of the month. So we are going to have our sessions. So thank you so much for joining. So today we are going to look at the concept of death and dying. Last time we were introducing what end of life care is about. And we were looking at different issues, and we introduced the issues of understanding the disease trajectories and understanding the functional status of palliative care phases, and how we can use this tool in planning of care for our patients. So we're looking around these disease trajectories and their effect or impact in our plan for patients. So we are combining both the palliative care phases together with the disease trajectory, which can then help you in preparing the plans for the patient across the chain. So we're looking at the stable, unstable, deteriorating, and terminal phases. We also looked at the pre-disease trajectory, which is a cancer trajectory. We also looked at the organ failure trajectory, and then we looked at the what is this? Frailty. So we said these are three trajectories. The cancer one is predictable, but the others are not. And then we can visit our YouTube channel to pick up from there. So today we will be looking at a closer gap on the death and dying concept, and look at the social, psychosocial factors that may impact or may influence one's experience of the death and dying process. So we will be looking around that one. For now, may I go straight to Mr. Zakele, who is our regional palliative care nurse stationed in the Shiselweni. He will be presenting a case on a flight from the Shiselweni region. And may I request that as he will be presenting this case, may we consider that if this was a patient in front of you or at your care, what different you think you could do, or what do you think needs to be added, and then advises the CZ on how best you can do it in the context that we are living in Eswatini. So may I just give you, Zakele, this opportunity to present the case. I don't know whether if you want me to share the screen for you.
Good afternoon, colleagues. Mr. Matlang, I think there's no need for you to share for me the screen.
So let me share it for you. All right.
Yes.
Let me go do that right now. Okay.
Good afternoon, colleagues. My name is Mrs. Zakele Mkonda from the Eswatini Hospice at home. I'm coming under the Shisoleni region.
I hope you can see it. I don't know. You are muted, Mr. Zakele. Please unmute yourself. Yes.
Okay.
I hope you can.
Yes, the problem is when you share the screen, I can't talk here.
But now we can hear you.
Okay, Mr. Okay, afternoon, colleagues. As I've said, I'm from the Eswatini Hospice at home under the Shisoleni region. My case is a follow-up case of a female, 45 years old, who's single, who was diagnosed with cancer of the perianal stage 3. The client is stable, ECOG 2. The main problem or concern was that the patient witnesses severe pain on anal region and is unstable to sit or walk properly. Thus can no longer do daily activities. And also client is undergoing chemotherapy, but cannot attend all cycles accordingly due to lack of funds and family support. During the visit, the client complained of severe pain on the anal region and swollen lower extremities. The pain was in the anal region and it was burning, the pain description, and chronic pain. The scale was 8 out of 10 and the pain was constant. And the type of pain was background pain and the impact of pain on functionality was severe. And the current pain medication taken was weak opioids, which had partial control. And the vital signs were 120/68 BP, then pulse 98 beat per minute, then temperature was 36 degrees Celsius, then respiration rate was 20 beats per minute. Under the distressing symptoms ranking, patient had moderate depression. And under the significant medical or surgical history, client had done colostomy last year. And the past medication used by the client was a treatment, folic acid, multivitamin, parasulfate, tramadol, and paracodaine, and diclofenac. The social history. The client's education is a high school level. Then lifestyle habits. Client has no smoking or drinking habits. Working status, client is currently unemployed. And the client worked as a cleaner but couldn't continue due to disease progression. Then client complains that the family members discriminate her and don't want to assist or help her. And the client is mild hopeful under the spiritual history. The advanced care planning, client had not interest in the advanced care planning. And the further plan of care to improve the quality of life of the client was to continue palliative care with the client for pain relief and management of other symptoms related to her medical condition, and also engage social workers to talk to family members. I think that's it, Mr. Mashako.
Thank you, Mr. Mcc. Mr. Mcc has just shared a case. I hope, colleagues, you have been able to follow up on this client as he was sharing. Let me just summarize what the notes I've just taken from the case. This patient is a second patient who is still at his prime time in terms of age. Actually, is in his 40s, and then was diagnosed with CA perianal, and is categorized to be stage 3. And based on the presentation, the patient is on chemo, but then there's an issue of adherence to that chemo. In terms of functionality, this patient is stable, but this patient is on ECOG 2, meaning most of the time you can't give him now a lot of work. He's a little bit somehow dependent on the family members, but he can still ambulate around, but you can't give him work. So 50% of the time he's be on the bed. So I've noted that he presented with the severe pain, rate out of 10, that is more constant and not well controlled by the weak opioids that she's currently taking. And I've also understood that he also had this issue of family discrimination and neglect, and is experiencing edema. And he has a history of colostomy last year, and it's due to the condition. And another issue that Mr. Mcc has shared in the psychosocial spiritual dimension is that this patient is having mild depression, and also this has an impact because spiritually now he has a mild hope when projecting on the future and concerning her life and life after. So that's what I can say. Maybe I will give to you colleagues to share. If you wanna see something from the script, you will just ask me, I will share it back again. But may I give you two now to say what are the concerns you can extract from this patient and how best we can manage in this situation. You can just raise your hand, Yebo. Mr. Matsenja. You can unmute Mr. Cyprian.
Good afternoon, team. Thank you, Mr. Mcc, for the wonderful presentation. But my concern is about the discrimination part. I think that's why the patient is even depressed. So did you get any social worker to talk to the relative as well? And how do this patient believe? Did you include any pastor or priest to attend to the client's the spiritual beliefs part, the spiritual belief part? So that's my concern. And I also want to know where does this patient get the colostomy bag? Because I understand the colostomy bag was a problem before, there was no colostomy bags, in some departments, I was told that the patients are using plastic bags as colostomy bags. That's why sometimes you find that the colostomy is infected. So where does this one get the colostomy bag? Thank you.
For your contribution. I hope Mr. Mrs. you are noting, and also colleagues you are also noting from the contribution. And by the way, Mr. Masenga is our national Babane patient navigator and palliative care focal person. So yeah, thank you, Mr. Masenga. Anyone else, colleagues, who may want to add on this client? Umelelo, I can see you here raising your hand. May you drop your hand, Mr. Cyprian?
Thank you so much. Can you hear me?
Yes, I can hear you.
Thank you very much. We thank Mr. Mkonda for the case presentation that he has just presented to us. I also had the same concern as Mr. Matsenjo, and maybe I didn't hear him talking about the family support. Who is around the patient? Who is supporting her? How many children does she have? And all those family history things. And I also didn't get the part where he visits the patient with other people, other team members, like the social worker and maybe the people that deal with religious beliefs and the spiritual part of the patient's history. Thank you so much, ma'am. I wish he could answer us so that we do not dwell on one and the same thing until the time is up. Thank you, ma'am.
Thank you, Mhlanga. I guess since you can address the two comments before we proceed to others. Mr. Mrs. you can unmute and respond, yes.
Okay, thank you, Mr. Shumasang. About the social worker issue, the social workers were involved, and the client is staying with his brother, and the brother was met, and the brother promised to cook for client, but mentioned that client is always complaining and bad-mouthing him to people, and he is considering looking for a distant job, leaving client by herself. Under the spiritual was involved when we combined the presentation, and under the colostomy bags, clients used to collect the colostomy bags from the Look Commission, but I'm not sure where is she getting them right now. I don't know if I've answered everything.
Thank you. Thank you for responding. I don't know if someone else want to comment, but that's what people has said. They said that they also engaged the spiritual person. I don't know if this client have a church or a community, because I guess if she has a spiritual community or a church, it will be very beneficial at this point in time, especially that the relationship between her and the brother is a little bit cracking. But let me go straight to the social worker. Mercy.
Thank you, Mr. Mahlangu, and good afternoon, colleagues. This client was seen by the oncology palliative care team and the home-based care palliative care team together, where we were able to conduct a family meeting with the present family members, which are two of her sisters and one brother. Unfortunately, the other brother was at work. He could not join us for the meeting, but he had been supportive financially to the client, assisting in terms of buying groceries and other needs for the client. And then one of the sisters during the meeting did say that she is going to continue supporting her sister to be able to have transport money for chemotherapy because she lives far. The other sister, I'm sure Mkonda did mention this before. It's unfortunate that I came in a bit late. The other sister did distance herself. She said that her husband doesn't want her involved with the family, and for that reason, she will not be able to visit the sister. She will not be able to even send her children at least for the client to at least take medication, be on an empty stomach. And she even said things like the community people, that's the only way she can. Otherwise, she's distancing herself from this whole thing. She's going to be in trouble with her husband because she's not allowed to set foot Kaigibo. There was also then a community member who did pledge to support our client in terms of the wound, to which she did do that for Sikashanyana Hamba. Then when we engaged Utilomzala, our client, he did say that people do come and support client yet who unfortunately because of indlela lakakhuluma ngayo, then people tend to move away from her because and people do in the process. To which then Mkonda did mention that she then said, then the brother did say that he is willing to continue supporting her provided naye uba umuntu lonakabo indlela lakakhuluma ngayo abe ngumuntu lombeketelelako because no one is working in the homestead. Naputi goes out and tries kuhlanganisa a thing or two ukuze ukuthi bakhone kulala badlile. The client has never been married and she does not have children.
Thank you, Miss.
So, and if I forget some, indaba yoku-involve udokotela and also maybe ukuthi indaba ize igcine ifike emphakathini because at some point there was a concern that the brother is chasing her out of the home. She asked us not to involve people from the community.
Okay, thank you. I don't know, how do we deal with such a patient? We have our palliative care expert here. Umelelo. This is your specialty, Mhla. Yes, you can respond.
Thank you very much, Mr. Mahlangu, and thank you very much, Shabang. Yeah, it is a complicated case, but I think the patient has some anger issues and she hasn't accepted her diagnosis. She is angry towards any and everyone who's trying to help her. Maybe if we can start on that part, just ask some questions in relation to the anger part, because she's mouthing everyone that is trying to help her. It looks like people. This one is angry. She hasn't accepted the fact that she's diagnosed with this life-threatening illness. And two, if we can find the exact reason, it is possible, though difficult, why the other sister's husband is refusing her to support the sick sister. We may start there and then we go broad as we continue with asking the questions. Even though she might not be around the sick sister, we can sometimes call her when the husband is not there, or even ask to visit them in their home. so that we find out the exact reason why the husband, because this thing complicates the sickness of the other person who is sick. Looking at though she's angry and she's bad mouthing everybody who's trying to help her, you may find that the husband has a reason why he doesn't want the other sister to support. And then after finding out all this, we may be able to maybe try and help where we can, as long as the patient has accepted the fact that she needs help and she's sick, she's unable to help herself the usual way. I think that's it. Thank you so much.
Thank you, Pumelelo. Yes, this is one. Some are trying to help, she's rejecting them. Other family members say, don't help her, even it's your blood, don't. It's a complicated and painful situation. To me, I see a lot of patients already in this scenario. Some are not having the cancer in their bodies, but it is in their mind or psychological world. They are really living with cancer that needs to be cured. Otherwise, they will be even harmful to themselves, which include their husband too. That we may not lose anything by helping the sick. Sometimes we may need to educate the families. You remember last time when we were looking at 3 disease trajectories, what was common across them all was that you need to educate their family members, and then because sometimes they don't understand what is going to, even the patients themselves. When we are educating the patients or when drafting their goals of care, you need to educate them. Reality and truth must be spoken so that they know exactly what is happening and consequences of certain decisions they are taking. So we can have both parties involved, because sometimes they will speak back like this patient is doing and think the others will just be normal as they are. And they will also have to resolve previous conflicts, because you may find that this is a long and old war that has been there. Yeah. But anyone else, you may want to comment on this situation. What can be done? Even though I'm looking for a hand, okay? I may add that even though these are the psychological issues, which has an impact on the level of depression, the family's dynamics may need to be worked around. We need some time with the patient to address the reality. Why are you so doing to your brothers? What is the root cause of this problem? What makes you behave this way? We then be in a position to help the patient and also address the issue with the brother-in-law. We may find time to also address that issue. Sometimes the family meetings may sit around to say, what do we think as a family makes the patient think this way? And then we may find a solution on going forward in that case. I may not be the oncologist to know the cancer stage at this point in time in terms of progression, but I've learned that this patient is not even complying with the chemo. My surgeon's team and the oncological team will say, you don't start chemo and not comply with it, otherwise it will be worsened. So I'm suspecting that this patient must even pass stage 3 very soon to stage 4, because now we are seeing some edemas coming, which may show that the liver or the heart may not be functioning well. Some of the organs that are responsible for water regulation might not be functioning very well. So maybe the liver might not, because then we are seeing some edema, they might contribute to some things. Or else something else like cachexia might be taking place. I know that since you might not have the scale to measure the weight, you might find that he has lost 5 to 10% of the weight, and that one will put her under cachexia. And that, if it's a key, this patient must be approaching the end. And if he's not prepared for that, he will die in sorrow. So I may request that even if I'm seeing multivitamin in the medication prescribed, but then if it's not working for this patient, chances are this patient might be in cachexia and anorexia, and anorexia during cachexia cannot be reversed. The cachexia cannot be reversed. he will continually lose weight because of the prognosis and the situation the patient is going through. And he might need some counseling because that one may have some psychological effect into her that he's losing weight and his self-image might be destroyed. And finding out the grief and loss this patient must be going through. Actually, end of life, death and dying, there are two partners together in terms of death and dying. So it's the same package because there's things that happen when you are dying, they happen when you are just diagnosed and going through the process. So I may recommend that we also consider the issues of proper checking, that if he has no pyrexia, and if he's there, is it at a refractory stage yet or what? And then there's the edema there, and then finding out what could be the underlying cause of the edema, and then addressing it with those like what is furosemide or whatsoever diuretic drugs to address it. So I think we can do that. And then the hygiene part of the colostome, I know that we have the supply problem with colostome yet. I don't know how the family the patient is pulling through. It's very terrible, especially for a lady. Let's continually support the much we can, even if the colostomes are not there. Let's look around on things to keep her as a lady and maintain her self-image on that issue. And then the issues of pain and the loss of self-care. Also, it comes with a loss and grief and loss on its own. So we need to also look around those issues and find out how is it impacting him, and then how can he be assisted. Sometimes the patient will have those anger issues, but letting the patient pour out what they are going through, it's also therapy. Let them talk, let them cry, let them say it, but we need to do the probing, find out, go to the deeper route, psychotherapy, so that the patient can go to terms with herself and accept their reality and find coping behaviors that are gonna help her adapt to the situation. So another issue that I've found that is also having this pain that is not controllable. It's unfortunate that we still don't have the morphine yet in the country, and we are relying on the tramadol as yet. But then please, I would suggest also check around issues of sleep and effectiveness of the tramadol 50. If it's not working 3 times a day, let's take it to 4. If they not, let's take it to 4 plus, and then put the 100 milligram 4 times. Then we see to the maximum dose. But then we need to watch close at the issues of seizures. If she is not a candidate that usually have those seizures, so that we manage, because tramadol is this side effect of seizure. Let's watch it close on those English. And then again, if then the patient is coping well, and then we monitor the issues of insomnia and stuff, it's able to rest and sleep, because sometimes those things they do help. And then another issue, I can say that at this point in time, it may sound like everybody is rejecting him. To her, it may feel like everybody is rejecting me. And I would say that let's look around the issues of faith, and let's look around the issues of spirituality and help the patient ride on her spirituality. If then is a believer of Christ, at least have time to pray with her, read words that will encourage her and drive her to God and make her feel loved by God. It can help her cope with this situation. If she is a Christian. But then if he's believing in other things, it would be best to also find the religious person who can help. And also make her feel loved, that even if other situations are happening, make her feel that the family loves her indeed, but even to forgive herself, because sometimes you may find that he has forgiveness issues, so maybe forgiving herself, he will be in a position to even accept the other family members. So I think that one will help, while we are also looking around in terms of getting the husband, the brother-in-law, to see why is the family so great, and why is she mouthing everybody, finding out that and helping her and make her understand how impactful is that on the quality of care she can get. Because I heard that she feels that she is discriminated, and we need to educate the families on how to deal with this stigma and discrimination is very detrimental on the patient, and also it affects in their future experiences with such a situation. So we need to help them address it and face the situation in a better way. So that's what I can add on these issues. I don't know if someone else may want to add something on this case. Otherwise, thank you so much, Mercy, and oncology team and our regional palliative care nurse for attending to this patient. We can give her the best experience she can get and address the pain she's going through physiologically and psychologically, maybe possible socially and spiritually. I don't know if I'm leaving someone who may want to add something before maybe I can go to our today's didactic presentation on this case. Okay. I don't know, but maybe to ask Mr. Mrs. Is there any comment you may want to add on this case as far as concerned?
There's nothing much, and thank you so much, Tim, for helping me and assisting me with the case. Try and work on it.
Thank you, Mrs. We wish you and your team the best as you work around this case. Thank you, team. I hope we are learning something from today's case, that how the psychosocial dimensions can affect the patients, and we need to also look around those issues. Thank you so much, team, for contributing on the issues of finding someone spiritual and addressing this issue. Especially what I'm taking away today is that we may be easily tempted to look around the fruits of the problem, all the psycho display that we are seeing on the patient. But I'm learning that indeed root cause analysis will help us address the root cause. Sometimes we may find that the root of the problem really are uncomfortable matters to deal with, but sitting down with the patient, sometimes like this, I want us today to discuss the issue on your response to your brothers. What makes you speak ill of them? I want us to discuss the issues of your family, you and your family today. Are you comfortable that we can discuss that? I want us to address the issue today. Last time you said they are discriminating, I want us to discuss on that. And try to help the patient to go for solution-based discussions rather than just dwelling on the problems, but finding on what can be done so we can move forward, other than dwelling on the issue that they are doing this to me, but the solution in terms of how can we move forward. I don't know what happened, but I saw myself dropped. So I don't know what is happening. But then, can I go straight to our presentation? And I hope I will finish. We have a serious network problem here. So can I share today's presentation? Thank you so much, Zix, for such a wonderful case. We are learning a lot from it. All right. I will share another document with you, colleagues, on IECO. So some of the materials, oh no. Some of the materials I will jump so that we can be in a position to, please, Mercy, if I drop off, just let me know. You can WhatsApp me or what. The Wi-Fi is not doing well with me. So, can you see my slides, colleagues? All right. Can you see my slide?
Yes, we do. You
Yes,
can
we
see.
can.
Okay. All right, let me fix something here. Because now I'm hearing you from another dimension. All right. Let's continue now. So today I want us to look at the concept of death and dying. I will try to be fast because I don't know what this network is doing with me. So bear with me when I'm very fast. It will not be that I want to be fast in that way, but you know. All right, so today I want us to define the concept of death and dying, understand the influencing factors to individuals' experience of death and dying, and describe the role of the interdisciplinary team during the time of death and dying. So I will just look at the overall on this. But as I've mentioned in the case presentation time, that grief, loss, and death and dying, normally they have similar characteristics in terms of psychological impact. So grief and loss, what happens normally in grief and loss normally happens during death and dying time. So we normally face the same thing. So in grief, we will have time to look at in depth in future presentations, but I want to just keep bringing to your mind that grief is the emotional response to any loss. And it's individualized and personalized feelings. So it involves the individualized and personalized feelings. For that reason, it makes it a subjective matter. And these include the responses that an individual makes to a real or perceived and anticipated loss, whether they are going to die, whether we are faced with the reality of death. So if there's loss that is going to happen, then the patient will have those responses. And the feelings that are most commonly included in this are anger, frustration, loneliness, sadness, guilt, regret, and sometimes some people will be calm and collected in the midst of this situation. And then again, we also need to understand that there are major concepts that we will unpack when we are doing grief and loss that are associated with grief. And those concepts include mourning and bereavement. So when it says grief, then we will have mourning and bereavement, these are the major concepts under grief. And we'll talk to this in depth about this concept when we are doing grief and loss and bereavement. So we also have loss, which is often thought of in the context of death and dying. And many examples of loss are not associated with death, right? Many examples. Other than the loss in terms of death, there are many losses each and every one of us may have experienced, or sometimes we're even experiencing even today. Some loss is perceived only by the individual experiencing it. You may find that yourself, you are experiencing a certain loss, but nobody else is experiencing it. It's only affecting you alone. And it's perceived by you only as a loss. You know, some people are losing a loved one or a boyfriend. And to others, it's nothing. But to them, it's big deal. So it's perceived by you also. But in other types of losses, you may find that the loss is visible to the individual. Other people can tell, really, you have lost something. Some patients, they feel like, I've lost a value. But we can't see that you've lost a value, but other losses we can see, you have lost a loved one, you have lost a car. So we may not perceive, but we can really see that loss has happened. And then we talk about death and dying. In simpler terms, this is the cessation of the biological life functions. Those specific conceptions of death may vary based on cultural and spiritual beliefs, but this is death. The biological life functioning has stopped functioning. Heart stopped pumping, lungs stop putting in and out of oxygen. You are just dead. An individual's perception about death and dying can directly affect the process of death in an emotional as well as a physical sense. So how the individual perceives death, it affects the very same process that the patient is going to go through. So your perceptions affects the patient's experience through the process. And the individual experiences and emotions about that, they differ. And individuals may experience emotions about that on a continuum from fear to peace. So you find that some patients are scared. For that reason, you find that we check on the issues of anxiety. And some patients are at peace. There's no hanging business to be completed. All things are done, they are ready to go. And these emotions may fluctuate within an individual over time. So today they are ready, tomorrow they are not. So they go through different emotional continuum phases. Today they are ready, tomorrow they are not. So we will see that how Kubler-Ross described those reactions. And then we can categorize into three. There is what we call physiological death, psychological death, and so when it's physiological death, that the body of the individual is unable to engage in necessary basic process, such as eating and eating. So the person cannot eat, cannot breathe, cannot move, cannot speak. They are dead. So the physiological death shuts down of the 14 systems, organ systems of the body. So the body shuts down. And then we have the psychological death, which then occurs when the individual begins to face their impending death and consequently regressing to the self. If a person begins to withdraw themselves, they are dying psychological isolation. They close themselves in the room. They begin not to engage with people. So now they are experiencing psychological death. So before the physical death happens, psychological death also took place before physical death happens. So whenever you're approaching a patient at the end of life, understand that they are also going through psychological death, and we need to help them not to even die psychologically, but to be held psychologically regardless of the prognosis of the situation until the last breath. And also we have what we call societal data that occurs when others perhaps are able to effectively cope with the imminent loss and its implication, withdraw from the dying individual. The Wi-Fi is playing me games. So another situation that we need to understand is the emotional journey of the dying person. So Kubler-Ross has this emotional journey of the patient. They first go for denial, where they refuse the reality of death, and then they move to anger, and then they are angry and they deny everything. And they become so very angry and hard to deal with at this point in time. And they accept death. Sometimes they go for bargaining. What if I can have this? What if I can do this? At least if I can have this time. So they need a bit more of time. And then they go straight to depression, and then they realize that nothing really they can do at this point in time. And now they become more sad, and they are going to a lower mood most of the time. And then later they go to accepting the reality. We will have some time in the future to look at how this emotion goes. They don't just follow this sequence. They are intertwined. Sometimes they are accepting, sometimes they are depressed, sometimes they have anger, then back to denial, and then from bargaining to... So they are up and down. So this is a tornado time. But these are the symptoms, and they don't just follow this ladder like they are climbing, but they don't just do that, but they go in like a tornado. They are up and down the journey. And then we have the pathophysiology of death, or the stages that a patient might go through when they are going to die. There's an early stage, the middle stage, and the late stage. Most of the time, we easily see patients who are already in the late stage. It might be difficult to see the early stage, but what we have tried to present today here is to put the key indicator that can tell this is an early stage of death. And most of the time, when there's an early stage of death, you will see the patient having reduced energy. This patient will begin reducing oral intake, like they eat less and drink less. And this is very stressful for the patient. And this one can be few days to weeks, sometimes months. for these patients when they are reducing the diet. And then people will be forcing this patient, will be coming with this multivitamin stuff, we're trying to force them when they are approaching the end. At this stage, you need to understand that they are reducing the energy. The body metabolism is going lower, and there's no need for any glucose and stuff. The body is using what it has and it's going down. And this patient is marked by noticeable decrease in appetite, and sometimes the pipes will shoot up and show up. So you'll find that once then they begin to decrease their appetite, report that one most of the time, they are at the early stage of death. And if you continually feed them by force, you will find that they will choke on fluids and occasionally become full quickly. So it suddenly comes early. They are easily full. The relatives will say, we feed him 2 spoons, and then he said he's okay. And actually, it's true, he's okay. Don't force more fluids. We say here, feed the patient as tolerable as possible, as the patient can tolerate, feed the patient. If they don't stop, do that because they are in the stages of death. And then immediately, the patient is increasingly unresponsive to the surroundings. They have detachment at this point in time. And sometimes at this point in time, you will find that even their blood pressure changes. So the body circulations begin to slow down. Blood is reserved for helping the major internal organs to function. So the vital signs, they change. They begin to be colder a little bit. Blood pressure goes down. Sometimes some other period, blood pressure goes up. But at this point in time, they begin to be detached from the surrounding. If you speak with them, they're not responsive that much. They are detached from the real life experience. And then at the end of the day, the patient is bedridden, with the caregiver holding their hands, always there helping the patients, and sometimes they're disoriented and restlessness. Patients, then the caregiver, this stage is so distressful to the caregivers, and sometimes the breathing and continence are significantly altered. There's more of labored agonical breathing, and there's also incontinence taking place. Sometimes bowel movement cease completely, or they are incontinent. So you need to know that now that our patients are going. And you need to educate the family members about these 3 phases. That when you see these are signs that death is by the door. Patient might go at any point in time. Yeah, my internet is not playing good with me. Okay. And then we have signs of impending death that we know, especially the last hours. There's terminal breathlessness and terminal agitation, fading of consciousness, sensory changes like illusion, delusion, and hallucination, and death awareness. What we can say that is that end of life hallucinations and visions, they are common at this point in time. You hear that patients are talking about their fathers, they are talking about their aunts who died a long time ago, and they are finding peace with it. You know, other than giving them haloperidol to deal with the confusion and hallucination, it's better to listen to them and understand what they are saying and the meaning of whatever they are sharing with us at this point in time. And most of the common things are just so scary to family members, that the altered breathing pattern, the chinistose breathing, and agonical breathing. So then now they labor breathing, they are pulling breath very far from their house, they are breathing very noisy and stuff. And these are the most distressing times with the patient. So I compiled the PDF and I will share it on our iEco platform, which details the changes that happens in each system of the body and the signs that you can see from each. Please, you will access it in there. So it is in this PDF. So then we need to understand also, not talking about death and dying, the issues of life-limiting and terminal illness. Terminal illness refers to a disease state for which no cure is known. Actually, there's no cure for this state of the patient. So we need to understand that. Then, unfortunately, what makes it so strange and difficult is that it is very difficult to predict the time of death. When will death occur if you have a terminal illness? It's very hard. For that reason, I say let's intervene in palliative care and hospice care whenever necessary, as possible as we can. And we need to understand that nowadays, other than in the past, survivorship has increased, especially with life-limiting conditions. Patients with this advanced treatment, they can live longer than we may think of. So then, the life expectancy of any patient with life-limiting disease, it varies and it's dependent on the disease state. So you cannot easily detect that, oh, okay, this one will die tomorrow, what? So it varies with patient to patient and it's dependent on the disease state. And terminal illness in terms of on hospice and palliative care is when then now life expectancy is less than 6 months. Then now we can say we are for palliation. And these are the conditions sometimes you may find that patient may have a life-limiting condition. There's a certain level of cancer stage, whereby we say stage 4, life-limiting, stroke, host disease, HIV, maybe end-stage heart, lung, kidney, liver disease. So any organ failures at the end stage, muscular dystrophy, multiple sclerosis, dementia. These conditions can be categorized as life-limiting conditions at a certain stage. And sometimes we need to understand that the type of terminal illness and prognosis affect how patients and families respond. So, and how the treatment is provided and how insurance companies cover the cost. We have the experience that we have those patients who have medical cover, but then at some point the medical cover is completed or it has limits. You cannot go to this level. So then the terminal condition and prognosis affects that one. Okay. Another thing we need to understand about death and dying is that also children have terminal illnesses, and sometimes it poses several challenges as compared to with adults. So terminal illnesses in children may tend to be caused by rare diseases that are not common in society and may be associated with specialized care. Children need to be admitted to hospital for a long time sometimes and may be associated with very short or very long duration of illness. So this is a complicated time, and caring for families of children with terminal illnesses poses a unique challenge indeed, because children are very hard to deal with. And sometimes you may find that challenges include factors associated with the following issues, like travel to treatment centers with children is very difficult sometimes. Cost of family travel, they need to travel up and down Babane, from Lafumisa to Babane, because the only children on call you have in the countries in Babane. Family dynamics associated with siblings. We have siblings visitation might be difficult to deal with. They also sometimes we find that there's a financial burden to the family depending on the insurance status. You find that maybe sometimes the finances will be depleted. And sometimes with the emotional burden on the siblings, you find that the siblings of the child are uncoping to see their loved ones anguishing in pain, and sometimes when the prognosis is becoming poor. And sometimes there's a high levels of fear and anticipatory grief. You know the parents. There will be always a high anticipation of grief. Okay. And then again, we need to understand that terminal diagnosis of a terminal illness have effects on the patient and the family. The patient side, there are profound psychological effects of receiving terminal disease news, and then the patient will go through anger, anxiety, and fear. And it's very important to help the patient maintain the best quality of life for the duration of their illness. Regardless of whatever the news, they must be broken, and we need to ensure that they have quality of life as possible as we can. And if then there are psychological effects on the patient, same to the family members too. And we discover that there's significant change in life expectations. The family begin to have different expectations concerning the patient. And if this is not addressed when we are planning for the goals of care, then you find that there's fragmentation in terms of the plan of care, the direction the family and the health providers are going. For that reason, the interdisciplinary team needs to be united so that we can help the family address the issue of life expectations. And sometimes there's an increase of sense of distress and panic and grief and there's change in the family dynamics as their family roles are changing. If the father is sick or the mother is sick, their family roles changing, and the family dynamics will also change. Find that children now they became parents, and treatment plans and progress and change. Because of the treatment plans, progress and change. You know, with this terminal illness, we will keep on coming with bad news for the families, saying that we are withdrawing certain drugs, we are changing certain drugs, drugs so and so is not effective. So there's always changing plans. Now we are moving you for hospice, now we are moving you for home base, we are taking you home. So there's a lot that happens. And at this point in time, family dynamics, they also change when then there's an increase of patients need activities of daily living needs at end of life. So as the patient is approaching the end of life, as we've shared in the previous slide, they have an increased need for support with their activities of daily living. And believe me, those patients on the frailty trajectory, they easily get tired. Actually, they get tired of providing the care for these family members. So the family dynamics then kicks on them. And you find that there's a caregiver neglect, there's burnout, then there's abuse, like the case we've already taken care of, family member issues coming up, and then some family members end up neglected. So we need to understand that end of life and terminal illness comes with those challenges. So then there are key roles we can play as an IDT. So one of the things during end of life, the focus that we need to understand that when your patient is at end of life, the major focus now is communication, ensuring information flow, communication between the IDT teams, clinicians, between the patient and the clinicians, the family members, communication between the patient, the family, and the clinicians. It's key. So we need to explain it out. There's nothing so painful to go to Maban and then they give you hope. Go to Manzini, they break you the news. Go to hospice, they tell you another thing. Go to the clinic, they tell you another thing. You end up confused. So communication is key at this point in time. Another focus at end of life during this period is emotional support. Supporting the. Do you know that as clinicians we also go through grief? So we need emotional support between one another. We need to support the families, the caregivers, and the patient. So emotional support at this stage is critical for both the clinical team and the family and the patient. And another thing we need to understand is the issues of palliation of distressing symptoms. We need to focus on benefit and risk, burden of treatment, decision making, relieving and promoting comfort, ensuring that everybody is pain-free and as we move forward. As I was mentioning in communication, is when we are disclosing the plans of care, diagnosis, prognosis, we are disclosing truthful information. And then another issue that we need to also deal with is the autonomy and empowerment. Here we are giving the patient the time to make decisions concerning their care, supporting them. Education is empowerment, giving them the power and knowledge to make decisions. We call it informed decision. Why is it informed decision or consent? Is that the clinicians provide detailed information for the patient and the family to make decisions autonomously. So empowering them at the end of life is key so that they make good decisions. This statement, self-empowerment for terminally ill individuals has been associated with a perceived ability to better manage medical actions, changing life goals, and the psychological impacts of illness. This one is one Wakefield at R28. This one is. So we need to empower these people so they can self-manage themselves. If they want to go home, let's empower them how to manage the patient at home, how to do this, how it is done, so they can self-manage themselves. And factors influencing a grief and death experience, there are many, but we will be looking at these factors in our next module in depth, especially this first one, which is developmental consideration. This one has a very role in terms of how individuals experience death. different individuals, toddlers and grannies, have different experience of death. So this may include the life stage of the dying individual, the social stage of the family. The experience of a family that is at the childbearing family experience death differently like an empty nest family. So they experience differently. So what stage is this family in? So it also affects that one. So there's developmental stage consideration. How younger children and adults and the younger adults experience differently. And these factors, they influence the treatment plans, the terminal illness progression, family expectation, grief, response to loss, and individual experiences of loss and grief. And we will unpack this in our next session in April, where we'll be looking at the developmental factors. How does each patient in the life cycle experience death, so that we can understand when we're dealing with children, how they interpret and feel about death and dying. So we'll look at this one in April, so that I will not dwell much in it. And then we have the we have the socio-economic factors. They also play a major role in how we experience death, right? We are talking about this patient we have been discussing about today, saying the issues of access to certain resources, even the issues of going to take chemotherapy. Mr. Msini said that these patients sometimes default the treatment because of the lack of financial support. So socio-economic consideration, they play a major role because access to care and financial resources are available to the individual. They have an impact. If you have resources to go to get services everywhere you can go there. For example, geographical location, where are you coming from? How is the family where you are coming from? They also affect access to service. There's what we call disparities or determinants of health. Now, one of those things, the social issues that the patient is going through, the financial resources, having access to financial and social support plays a major role in terms of your experience with them. Who will be there with me? How will I get supported? Will I get the pain medication as required? So those are the things that we need to consider when we are looking at the social economic factors. And other economic considerations in death and dying may involve paying for the care of the body. You know, now the patient has died, which mortuary the patient is going to be taken to? The funeral cost, how will the funeral look like? For the patient to plan for their funeral, will they have the funeral cover? Sometimes there are assets that need to be resolved, and there are costs that will come there. So social economy, they put very distressing times and experience of death. So if all these things are not put in place in order, then disaster happens. And varying beliefs and views around medical treatment and issues of death discussions. I have life experience when I wanted to discuss death and dying with a certain patient, family that I already identified that this patient, actually my patient was already in the middle stage of death and dying. And when I introduced the news, they couldn't accept it. But believe me, we then went around that one, but when the situation happened after that education I had with them, they appreciated. But then, the beliefs that we have even in Swaziland, we don't talk about them. We don't talk about it. So yet, these varying beliefs, they make the experience very tough. For that reason, you find people full of food in their mouth that they cannot swallow because the varying beliefs we have around that. People will be taking patients to the hospital on emergency, saying that they need fluid, IV fluid, they need feeding and stuff. Can you, the hotel put the energy tube and stuff? Those are the things that are affecting the patient. So the social economic factors. And then the cultural consideration, they also have that one. I think for us in Eswatini, we have a good case of this, that really cultural values influence grief and death. The rituals and mourning practices. Indoors are cards. Men don't cry. No, you don't cry. Children, sometimes they are silent. They are not supposed to be crying when death has happened. The rituals that are there. A woman, this is what we say, you don't cry. Cultural awareness and inclusiveness and atmosphere guide the care plan. So when we then don't understand the cultural inclusiveness, and the culture has a lot of things that happen. The roles, the custom, relationships, expected behaviors, the thoughts, the manner of interaction, the language, what can you say, what we cannot say. You can't tell my mother that we don't speak this way. This is not our culture. We are aware of those things. They affect the experience. Other people are deprived of their peace. They are deprived of a good day just because of culture. And whenever we are planning for end of life care, it must be centered around the cultural sensitivity and individualized cultural experience. And then also we have the psychological factors. So dealing with death and dying and subsequent grief is a deep burden for both the carers, the caregivers, and the patient themselves and the family. So we are all gonna get a deep burden of this experience. Think of it, you are working in a ward, experiencing death after death after death. You are working in home base, you are told patients always died and died and died. It becomes a burden. Think of the families and the caregivers. So I always say the psychological factors say there's what we call, I call this a cycle of emotion. You know, a cycle of emotion, a tornado of emotions. When you are going through death and dying, grief and death, you go through this tornado of negative emotions during this process, including sadness, guilt, fear, anxiety, peace. So it's a tornado, like Kubler-Ross has put it. It's a tornado of emotions. I call it tornado. It's a tornado, it bombards you. It takes you to one direction to another direction. So you can't be stand still in the emotion of death and dying and loss and grief. You are tossed up and down these emotions, and it's a tornado, and it's affecting you. We wish our parents could have peace, but they go through this and they need more of our support. Some of our staff members, they go through this and they need our team support. And then also, what also affects this is the poor coping skills. If then the patient has poor coping skills, you find that the emotional cycle triggers an onset or a recurrence of depression. So this family has a background of depression, but then because of the poor coping skills in the midst of death and dying, in this tornado, then they are affected. So it's very important to know the coping procedures. At Hospice at Home, we have what we call psychological assessment tool. It asks for coping adapting behaviors. So in the tool, we have maladapting behaviors and good adapting behaviors. So we're treating the patient so that we know which adaptation behaviors the patient is using. Then from there, we are able to redirect or guide the patient to good adapting behaviors. So that will help us to assess that should there be tornado of emotions, how is my patient gonna cope? I'm taking it from the coping behaviors my patient is currently using. So that will help us to help me address and put in the issues of motivational counseling as early as possible. And also underlying mental health disorders, they have an impact. Increased psychological instability during grief. So it can be influenced by these issues. So when there are underlying psychological issues, they will increase the instability during grief. So the patient might be feeling this tornado of emotions more severe. And these individuals with psychological issues, they require sensitive support and straightforward discussions about their mental health and safety. And I propose maybe the parent we are having of MCs might need this. So that we may be sensitive but straightforward with her, so she can come to reality and be safe, because 1, 2, 3, this patient will commit suicide. Another factor that influences grief is the type of death. You know, the type of death may be sudden death and anticipated death. The death that takes time to happen. And so if it's sudden death, we couldn't have. You will hear the family say, we didn't have the opportunity to say bye. And sometimes they say, he has spent a lot, Lord, take me. So then, whether it's sudden, whether it's long time coming, it has an effect, but then the reaction of the people, they will differ. So the type of death will also influence the patient and the families. So they will react different. Some, the surgery will be more painful, but the anticipated death, they will have time to grieve in a long time and accept. So the type of death, they will differ. And sometimes not being in a position to see that death is coming will become a problem, and the death will sound saddened because they still had hope. But then the clinician couldn't enlighten their eyes on what is happening and help them prepare. So it affects both the dying and the grieving process. So we need to address and understand what the patient are going through. So reactions to death often depend on the time to anticipate the event, as I've mentioned already. And then the medical condition also affects your experience. Medical conditions are the most common cause of an anticipated death, right? If you have stroke, it's very hard to anticipate death is coming. But with cancer, sometimes we can tell when the patient is going to die because the trajectory, if you remember the cancer trajectory, immediately it goes down. It can be faster, but you can tell it's going. And then the organ failures, you remember that one. It's very hard to predict because the patient follows the same cycle path. With a good monitoring of the functional status, you can tell when your patient is going down. So the medical conditions are the most common cause of anticipated. You can tell that is anticipated and my patient is going to die. Chronic illness and conditions may be lifelong disorders associated with various complications. But maybe in conclusion, I would like that many of the challenges I've shared above, by anticipating these challenges with our patient, clinicians can proactively provide families with options, care, and support resources. We can. If we can anticipate these challenges, then we can be proactively, other than reactively, proactively provide the families with options, care, and support resources. A team and family approach is crucial in helping these families at this point in time when they are faced with the end-of-life experiences and challenges. And nurses coordinate and work directly with social workers, right? Providers, specialists, home care providers, and palliative care providers to create the best care plan for the patient. In short, collaboration within the interdisciplinary teams ensures that best care plan for the patients are always in place and executed. Thank you so much. I think that can mark the end of my presentation for today. Thank you so much for attending this session. So I was just summarizing for the issues of death and dying concepts. What do we need to understand about death and dying? And what can we do? What can we anticipate? What influences the death and dying experience? But then we will very much on the life cycle in terms of developmental stages in our next session to unpack how each developmental stage goes through death and dying. But that's all what I can have today. Yeah, but I can open up for anyone with a comment. I'm having 10 minutes before we conclude today's session. Anyone with a comment? You can just unmute and share. All right. I like it that way. So thank you so much, colleagues, for attending. And thank you so much for the case, Mr. Msisi. I hope we have learned a lot. And thank you so much for even with this didactic presentation I've already shared. I hope it has enlightened some of our eyes. We will now all be able to categorize the death stages of a patient and we'll be able to identify at what stage this patient is and be in a position to support the family and develop a best care plan for them and put them in alert anxieties. We'll be in a position to help them experience a good death. You know what? There is a good death. We can give our patient the opportunity to experience peace and comfort. Go in peace, because death is not the enemy, but we are here to give patients the comfort as we can and give them comfort. regardless of the diagnosis and prognosis. In the absence of questions, I would like to say thank you so much. Is there anyone who might want to volunteer for the case presentation in our next session? So our next session will be on the 2nd of April, just after April 1. We'll have a session on the 2nd of April, whereby we will be looking at dying and death across the life cycle of a person. How each individual experience death and dying. How each individual experience death and dying along the cross cycle. So that now we know this is death and dying. How then each individual goes through that process, so that we can be in a position to support each and every patient, regardless of age, regardless of family social stage. We can be able to help families, be able to support them, to help patients across the developmental stage in the life cycle of a person. How is it experienced? Thank you so much. Thank you so much, Margaret. Yeah, network was not good, but I thank God that today I didn't have time to go back and edit like last time. So guys, visit our YouTube channel. My video will be always there. Our video Eswatini Hospice at Home channel. You go there, Eco Eswatini. Today at 3:30, you will find the video for this session running already in our YouTube channel, and other previous videos are there. Thank you so much. Have a nice day. See you on the 2nd of March, on the 2nd of April. Thank you. Thank you. Bye-bye.